Well, the clinical uses of non-steroid anti-inflammatory drugs, of course, they are connected with pain like headache, toothache, myalgia, back pain. We have discussed that on the previous topic in narcotic drugs. When the patient has a severe pain, very difficult to stand, he has to use the narcotic drugs. But if there is a pain which is acute, which is quite strong, but not that much, we can use the non-steroid anti-inflammatory drugs. We also call them painkillers because of that. Okay, in case of fever, we can use it because reducing body temperature by affecting on the brain, reducing prostaglandins, which stop stimulation of the thermoregulatory center of thalamus. In case of arthritis, rheumatoid arthritis, osteoarthritis, gout, and ankylosing spondylitis. Why? Because all these diseases, they are actually the acute inflammation. In case of dysmenorrhea, sometimes in period, women have pain, and especially ibuprofen is used in that case. Unclosure of ductus arteriosus, especially aspirin, can be used. So this is actually a newborn pathology. How to say pathology? Actually, fetus, he has some specifics of the blood flow because he doesn't breathe with lungs and he doesn't need a lot of blood to go to the lungs. That's why in his artery he has that ductus arteriosus, which like develops the volume of blood. How to say it? Not develops, spreads, reduces the preload on heart by taking some blood from the artery, from the lung artery to the aorta. Okay, and the opening of these ductus is dependent on prostaglandins. Well, also the last, prevention of myocardial infarction, stroke, and reinfarction by aspirin. Why? Because these pathologies are often connected with the formation of clots in blood with high aggregation of platelets, for example, and high blood clotting. So the non-steroid anti-inflammatory drugs, by reducing this and making blood more liquid, they prevent myocardial infarction, stroke, and so on. Rheumatoid diseases, like here you can see, it's gout, which starts from the toes usually, and some other diseases like arthritis. This is arthritis, and there are a lot of such kind of diseases. They are usually autoimmune. Non-steroid anti-inflammatory drugs, they also have many side effects, and the very important side effect of them is gastrointestinal toxicity. What happens in the case of non-steroid anti-inflammatory drugs? People develop peptic ulcers and multiple microerosions in the stomach, esophagitis, and so on. And why this happens? Because prostaglandins, which are some of them responsible, especially prostaglandin I and prostaglandin E also, which are responsible for the protection of stomach, because they stimulate the special prostaglandin receptors in the stomach, and these receptors are responsible for stimulation of the secretion of protective mucus, and you know that mucus, which contains bicarbonates, HCO3, it is responsible for reducing the acidity of the pH in the stomach, which protects the mucosa from the acid, actually, from the HCl. Okay, and when we use non-steroidal anti-inflammatory drugs, we block these prostaglandins, which are very, very, very important for the protection. So, okay, we have less protection. And finally, we have more acidity, and our GIT suffers. On kidneys, it can actually lead to reversible and acute kidney insufficiency, water electrolyte disorders, chronic kidney insufficiency, and so on. For the cardiovascular system, of course, everybody understands that it can be, it can lead to thrombocytopenia, and also it can increase the arterial hypertension and static cardiac insufficiency, and stenocardia can be. In the liver, it will be increasing of transaminases level, and in CNS can lead to headache, but actually it's this is the effect which can happen with every drug, because actually these painkillers, they are used to treat headache, not to cause headache, okay? But everything can be. So about blood system, I already said thrombocytopenia, hemolytic anemia can be, bones and joints, some disorders of cartilage because of loss of some cations, like magnesium, for example, and increasing of asthma, for example, and polyps in nose, skin rash, and so on. Increasing of asthma, why it happens, we will talk about that later when we will talk about leukotriene drugs, okay? And I will explain why this happens. Okay, let's go further. Contraindications. Pregnancy, why? Because it affects the blood flow of fetus. We have already discussed. The fetus has some special ducts which helps to not overload the heart, and if you have used the non-steroidal anti-inflammatory drugs, nevertheless they help to keep pregnancy and avoid the spontaneous abortion. Nevertheless, it can affect on the heart of the fetus, which we don't want. Hemophilic patients, I think this is obvious, because these drugs, they also make more liquid blood. Hypersensitivity, of course, viral infections, mainly in children, and for the peptic ulcers, of course, because they lead to worsening of situations. The drug interactions, of course, potentiates the gastric irritant effect of alcohol. Why? Because direct irritating with alcohol and indirect irritating with NSAIDs, and potentiates the hypoglycemic effect of oral hypoglycemic drugs. Okay, this we will study 2 topics later. The Salicylates aspirin. Aspirin, this is one very special drug. Why? Why this is special? Because in low doses, aspirin has more affinity, low doses. Aspirin has more affinity to inhibit cyclooxygenase of first type, cyclooxygenase 1. And in higher doses, it inhibits both cyclooxygenase 1 and 2. 1 and 2. Okay, so this is very special. Not all the drugs can do that. So what is interesting in this slide? The duration of action, okay, taken orally, it's a weak acid. So, about this, my favorite question. The drug is a weak acid, so acidic drug, yes. So in the stomach where pH is also acidic, pH is low, acid plus acid will be non-ionized. So if it is non-ionized, that means it is lipophilic, and it is easily absorbed, finally. Okay? So the rest is about the pharmacokinetics. Hydrolyzed in tissues and blood and converted in liver. Okay. The therapeutic uses of aspirin, of course, in high doses. So this is antipyretic analgesic effect, as anti-inflammatory, absolutely. But many patients cannot tolerate these doses because of GIT. So first, we should try the drugs like ibuprofen and naproxen because they have less doses and maybe less toxic effect on GIT, but I wouldn't say so. Actually, they also have a very toxic effect. And prophylaxis of disease due to platelet aggregation. This is in low doses. If here in the first we had to use such a big dose, 5 grams a day. Yes, it's very big dose. It's very difficult to use such. And for the platelet aggregation, we need only 100 mg for this, 125 and so on. But these doses also can lead to some toxicity, but of course less. Okay, and in preeclampsia and hypertension of pregnancy, sometimes if you are sure that this will be not a long use, not to make a threat to the fetus. Okay, so here you should be very careful for administration to the pregnant women. Okay, the propionic derivatives like ibuprofen has almost the same effect, a little bit less toxicity than aspirin, and half-life of 1 to 2 hours. What? The ibuprofen will have the same mechanism and pharmacological actions, but except that it is a reversible inhibitor of cyclooxygenase enzymes. By the way, aspirin is irreversible. Где там написано? Пироксин не туда вообще листаю, да? Aspirin is irreversible blocker of cyclooxygenase 1 and 2. Где это написано было? Нигде. Okay, so in anti-inflammatory effect, ibuprofen will be more potent than aspirin. Clinical uses will be almost the same, but it doesn't affect on platelet aggregation directly, only maybe like a side effect, but in the therapeutic action, it is not used. The preparations can be oral use, can be also some gel or creams for the applying on joints, for example, yes, and intravenous route for the patient with ductal arteriosus for the newborns. The adverse effects are the same and contraindications are the same. The concomitant administration of ibuprofen antagonizes the irreversible platelet inhibition of aspirin. So that means that if you administrate aspirin for the patient for a long time, which will reduce platelet aggregation, but at the same time you administrate ibuprofen, you can have less effect from aspirin. So be careful in this. Piroxicam. It is also a non-selective inhibitor of cyclooxygenase 1 and 2, and also traps the free radicals, which leads to reduction of the oxidation in the tissues. This is very good. It also inhibits the polymorphonuclear leukocytes migration and inhibits the lymphocyte function. We know that leukocytes and lymphocytes, they are a very important part of the immune system. So we can say that piroxicam a little bit inhibits the immune system, but not very strong. Okay, diclofenac almost the same. You can read it later. Also some topical use and with the rectal suppositories and orally also. And now about the selective cyclooxygenase 2 inhibitors. This is more interesting for us because they have some advantages. They're highly selective to inhibit the cyclooxygenase 2. They have potent anti-inflammatory effect, analgesic, antipyretic, and highly bound to plasma proteins. But for us, the best thing is that they have lower incidence of gastric upset. I mean, gastric ulcers and gastritis and so on. Also, they have no effect on platelet aggregation. They have renal toxicities and high incidence of cardiovascular thrombotic events, with some of them as prophylactic. Actually, some clinical trials were made about this question, and like they didn't find that really it was a big cardiovascular risk in the use of prophylactic. So here, this is not proved. They are recommended in postoperative pain, and in some adenomatous polyposis, dysmenorrhea, acute gout, and so on, they are administered. Okay, and now about the steroid anti-inflammatory drugs, also very important, but a little bit different. So steroid anti-inflammatory drugs, they are more effective than non-steroid anti-inflammatory drugs. They have more actions, they have more side effects, and we have already seen that they effect on phospholipase A2 enzyme. I will just remind you here once again that we have phospholipids of the membranes, yes, of the cell membrane, like let it be phospholipids. Then they are affected by phospholipase A2 enzyme. They form arachidonic acid, phospholipase A2 enzyme. With the help of this enzyme, from phospholipids, arachidonic acid is formed. Then arachidonic acid is affected by cyclooxygenase 1 or 2 enzymes and form the cyclic endoperoxides like prostaglandins and thromboxane and so on. Prostaglandins, leukotrienes, by the way, and thromboxane. Okay, so our steroid anti-inflammatory drugs, they work where? They actually work here. They block phospholipase A2 enzyme and stops the conversion of phospholipids into arachidonic acid, so all these products will not be formed. Okay, so they don't affect on cyclooxygenase, they affect only on phospholipase A2 enzyme. Так, okay, clear. Let's go how they are classified. The steroids and inflammatory drugs, they are classified as short-acting. They are natural glucocorticoids like hydrocortisone, cortisone. You know that these are our natural hormones. These hormones which are produced in our adrenal gland, the hormones of adrenal glands, of the cortical part of adrenal gland. And we have intermediate acting glucocorticoids like prednisone, prednisolone, methylprednisolone, triamcinolone. We have long-acting becamethasone, dexamethasone, and topically acting glucocorticoids. What does it mean, topically acting? That means that we can use them on the surface of the skin for example, or inhale them to our bronchi and they don't go to the blood, don't absorb to the blood, don't absorb to the blood. Okay, they stay on the surface of the skin or mucosa and don't give many side effects, many dangerous side effects, which can be. Okay, here it is the table of steroids in the comparison. If we take our cortisol as our natural hormone from human body and take it as 1, I mean the activity, I don't know, rate of activity, if we take it as 1 anti-inflammatory action, so the rest drugs are stronger or weaker than this drug. So let's then our hormone, then natural hormone. So now let's compare. Here you can see that these drugs become stronger and stronger. And for example, in the table, in the first like short-acting drugs, they are 4-5 times stronger and they have less salt retaining. Salt retaining, what does it mean? It means the mineralocorticoid effect, because in our body normally we have not only glucocorticoids in the cortical part of adrenal gland, but also mineralocorticoids and mineralocorticoid. And glucocorticoids, they give us also mineralocorticoid action, not only anti-inflammatory, also keeping the sodium inside the body. And keeping the sodium inside the body means keeping more water inside the body. This is effect on kidneys. So the cortisol, our natural hormone, as a hormone, it gives 2 actions, like glucocorticoid and anti-inflammatory, and also as a mineralocorticoid by retaining sodium and water in the body. So you see the rest drugs, they lose their mineralocorticoid activity. Да, видите, you can see 0, 0, 0 здесь уже. And we can say that this is good, because we don't want actually to affect our kidneys. We want the anti-inflammatory effect, okay? So you see that here, generation after generation, the anti-inflammatory effect increases, becomes more potent. So this is very good for us. Going lower and lower, we have the long-acting drugs like dexamethasone, betamethasone, which are 30 times stronger than natural glucocorticoid. Yes, okay, and we also have some mineralocorticoids, which have, you see, mineralocorticoid activity much more than in cortisol. And this is normal because these drugs are used for mineralocorticoid activity, not for anti-inflammatory action. Okay, let's go further. Again, here is the mechanism of action. Once again, see it. Once again, make a photo. I don't know. Remember somehow that glucocorticoids, they stop phospholipase A2, which inhibits the formation of arachidonic acid from phospholipids and prevents the cyclooxygenase formation of prostaglandin, thromboxane, prostacyclin, and with lipooxygenase formation of leukotrienes. So the clinical use of steroid anti-inflammatory